Okay, thank you, Vikram. Thanks everyone for allowing me to speak to you remotely. I'm sorry I couldn't be there in person, but I'm very excited to talk about the RNS system, which I think is literally the most exciting thing there is in medicine now. Obviously, I'm very biased. Give you a little bit about my background. I direct the functional neurosurgery program at Massachusetts General Hospital, which means I do epilepsy surgery and other surgeries to implant devices in people, for instance, with movement disorders or psychiatric indications. I've been here for about 6 years, and previously I ran the epilepsy surgery program at the University of Pittsburgh. Next slide, please. Okay. Thanks, Marty, for jumping up there and doing that. So there is a huge treatment gap for patients with drug-resistant epilepsy. There are 1.2 million people in the US on medication that is not working, having intractable seizures. Only 50,000 of those are admitted to an epilepsy monitoring unit, a comprehensive epilepsy center, and less than 1% of this total number are treated surgically, only about 6,000 or 7,000. So here's a little more detail on recent growth in surgical procedures. Epilepsy surgery is growing. We're training a lot of people in functional neurosurgery who want to do epilepsy surgery. In both places, established practices where the epilepsy surgery volume was kind of mid-level. It's exploded both times. These patients are out there waiting. Recently, we'll just stay on that slide for a second. The total number of resections actually declined a little bit, and that's been replaced to some extent by LIT, laser interstitial thermal therapy, or laser ablation. You see the RNS implant numbers are increasing, and I think we're really at an inflection point where this is going to increase quite significantly. Because we have the same biases against resection and destructive procedures in the brain, and just increasing knowledge about how to use the data and how to implement RNS therapy in broader populations of patients. Next slide, please. Okay, so why does this treatment gap persist? Quite simply, it's really hard to treat these people. And many have types of seizures and types of seizure networks that you cannot cure with surgery. And so the traditional way of thinking about epilepsy surgery is you have to find one spot in the brain or one region and remove it. And a lot of biases against surgery are because there has also been a philosophy in some centers that you do that at the cost of function in some cases, where the goal is just to make the person seizure-free. So there's some biases against traditional surgery. So examples of those cases are very hard to treat with traditional methods are seizure onsets that start from both sides of the brain, those that start in eloquent cortex, so that's cortex that you cannot remove without permanently disabling someone, to speech areas or motor control areas. They're part of a larger network, so you can remove part of that network, but the seizure still persists. So you put someone through the risk of a traditional surgery without giving them a surgical cure. Too large for complete resection. And those that are coming from multiple areas of the brain are generalized epilepsy. So the reality is that every single one of these patients can be treated with RNS. So all of those 1.2 million patients from the slide before, they can all be treated. Some of those are still going to be best suited for potential surgical cure with the traditional resection. So if you have a family member or child with epilepsy and they have a spot you can see on the MRI or otherwise diagnose, and it's safe to take it out, it should come out, and they may be seizure-free for the rest of their lives. But the really rewarding thing that has happened in my practice has been the use of this device to bring huge quality of life improvements in people who otherwise just continue to suffer and suffer because they have a more difficult seizure network. Next slide, please. Okay, so what's changing in epilepsy surgery despite the kind of modest changes in the numbers so far? Why do we have such reason to believe that there's room for really dramatic improvement and soon. And these are the reasons, really paradigm shifts in how we think about epilepsy surgery. These have been driven to large extent by the RNS device, because for the first time in the history of treating any brain disorder, you can put a device in and record activity and make decisions based on that activity. And I should say, this is a safe surgery and easy surgery. So that's another way it's really differentiated from these other techniques. I think that's important for you to know, and something we probably surgeons don't talk about enough. The hard part is figuring out the right place to put the leads. And Vikram has a harder job, in some ways, interpreting the data and using it than I do to put the device in. That's straightforward. So in having increased use of RNS, being able to record and simulate essentially wherever we think is best based on the data we have, we've really changed our thinking, first in terms of defining success. So it's really clear that you can absolutely change someone's life without making them seizure-free. You can maximize their quality of life. People can go back to driving sometimes when they have the RNS. They can continue to work. They can reduce the amount of medication they're on. They have some knowledge about their seizure onsets and a likelihood for when they may have a seizure. They have some control. They can exercise some control over their disease. This is huge. These are really big quality of life improvements for the patients. The way we think about the treatment and not having to remove the whole seizure focus, this has brought a lot more patients to epilepsy surgery conference than previously. These patients who weren't thought to have a focus that you could resect safely, they just wouldn't be presented for a surgical option. It literally wouldn't be discussed. It was, well, there's nothing we can do here. Now, the majority of patients that come through our epilepsy conference are complicated patients where RNS is a potential option, if not the main option going in. And this has been a marked change in the past several years in my practice. And certainly, let's say I started MGH in 2019, and it took a couple years really for this to kind of turn around. And now the majority of patients that come through, whenever we do an intracranial monitoring surgery, if we need to do that, we're implanting parts of the brain that are important for figuring out where we might put an RNS. Now, this ties into this localization goals paradigm shift. So not only are we trying to inform our decision for the part of the brain that could be removed, if that isn't an option, or if it fails in the future, we need to know where to do neuromodulation, because again, we have the device that can record seizure onsets and stimulate, and that's customizable to each patient. It's customizable to the patient's data, including their intracranial data that we can get diagnostically in a diagnostic surgery. Patient management. This is just a massive benefit. Vikram's talked about this, and you'll hear more about this in other talks. Next slide, please. Okay, so this gives an overview of a couple things. One is the state of the art in epilepsy surgery, and the other is advantages of the RNS system over other systems that aren't closed loop systems and can't respond to the EEG tracings in the way the RNS device can. So targeted stimulation is the way that RNS was envisioned. It's the way that most people began using it. You would put this on both sides of the brain. So bilateral mesial temporal lobe epilepsy, or temporal lobe epilepsy in general, is fairly common. It's one of those types of epilepsies that everyone knows you can't take out both temporal lobes, so you can do neuromodulation. And other onsets where, let's say it's a language area, someone doesn't want to take a risk for language dysfunction with a resection, or in a motor area. So this is targeted stimulation. And this works very well. What we found over time in combining the RNS with basically, you might think of two categories of approaches. One is in combination with a traditional surgery like a resection or a laser ablation. And the other is using the thalamus. So the thalamus is a hub for information flow between cortical areas. And it can put the brakes on seizures when you deliver stimulation there. And many types of seizures are recorded very quickly in the thalamus. So you can affect a wide cortical area with stimulation in the thalamus, and you cannot do that with traditional surgery to affect such a large cortical area. So you can only do this with neuromodulation. And you don't have to use a thalamus if you have something that's localized to a region of the brain. And it might be better to put the recording and stimulating electrodes both at the cortical level. And then these combination therapies, this is something that we do fairly frequently now. There may be large malformations or multifocal types of networks where you can operate with a traditional surgery in one part of the network, but then follow up. But you know that's not going to be curative. So you follow up planned with RNS therapy to address the rest of the network. This is kind of like doing resection to reduce burden in cancer, and then following with adjuvant therapy that's going to keep the patient alive for longer after you do the surgical resection. The reason I said that slide also illustrates the advantages over, for instance, deep brain stimulation is that you can see through just the schematics on that slide that you can personalize the therapy to the type of epilepsy. And the way that people use deep brain stimulation in epilepsy, it's very generic. It's kind of like VNS. They put the leads in part of the brain called the ANT, so anterior nucleus of the thalamus, and you just turn it on. One of those devices now, you can look a little bit at the data, but you can hardly see anything longitudinally like you can with the RNS system in terms of the signal. What the figure on the right shows are the structural connections between three, what we think of as canonical nuclei in the thalamus. And there are a number of nuclei in the thalamus, but these are the big ones that historically have been tied to modulation in epilepsy. And you see the ANT connections are in the red. That's connected to about a third of the brain. And these other nuclei that we're using kind of quite often now in RNS, still with ANT, but also centromedian nucleus and the pulvin, are connected to other areas of the brain and have particular use in different types of epilepsies that can be defined. And the field is doing a much better job of figuring this out. This is kind of the basis for the Nautilus trial, this idea of the centromedian nucleus being widely connected to areas that are important in generalized epilepsies. This is also the reason, next slide's okay. This is also the reason why you see the RNS data supporting the idea that if you choose the right spot, you can put this anywhere in the brain, and it should work for the type of epilepsy that you're treating. And that's supported by the kind of ongoing data coming out from different groups. And it's in contrast to this data, extended data from DBS studies that show that the efficacy is just not as good when you use a kind of generic approach to put DBS in just one part of the brain or thalamus. Other advantages are illustrated here. The RNS intracranial data, you can pick up a seizure in any of the areas you implant as long as the hypothesis is correct. So in terms, it's really interesting. If you have a failure of the RNS device to work, that's very helpful information. You have objective data that shows you where the seizure is not starting, where it's not propagating, where neuromodulation is not effective. And it's not that difficult to go in and revise one of these systems and put the leads elsewhere based on alternate hypothesis. So you're kind of never at the end of the road with this device. And of course, if it is working, then the data has been used to guide stimulation settings. Importantly, there really have not been acute or chronic side effects with therapeutic stimulation. This could be for a couple of reasons. One is a customizable nature. So the programming neurologist can look at the recordings and make sure they're not simulating physiologic signals. The open loop or DBS approach, it's the device just on, it's not discriminatory, and it's stimulating whether or not the parts of the brain are doing something that they should be doing or whether or not they're generating a seizure. And I think this probably has to do, it leads to this problem of a greater report of things like sleep arousal, memory impairment, depression, with ANT stimulation, what we call duty cycle or open loop stimulation, where the device is just on all the time. So some of these patients do just fine with that, but others, it's disrupting something in their memory consolidation, their mood regulation, or sleep. And these are problems that can be avoided with personalized responsive stimulation. Next slide. Okay. The entire field is aware of this gap in treatment. The ILAE, the International League Against Epilepsy, recently included neuromodulation recommendations in their updated guidelines. And this field does move slowly, but things are finally changing. And this is a big deal to point out to epilepsy groups around the world that, yes, if you have a patient who may not be a candidate for resection, but they're medically intractable, they deserve an epilepsy workup because we have neuromodulation. And we're seeing this in really around the world, certainly in the United States. More and more patients that come to epilepsy surgery conference who are neuromodulation candidates primarily. And this is a big change. And Marty mentioned in her opening presentation that's a minority of patients who you can get a surgical cure with the traditional surgery. And I wish that wasn't the case, but it is. And so we're really going to see, I think back to that chart in one of my slides earlier that shows the amount of surgery spaced by category. We're eventually going to see a big switch there. The vast majority of epilepsy surgery is going to be neuromodulation. It's not going to be traditional surgeries to take out a part of the brain for a cure, because those are the minority of patients. Okay, next slide. So I think this is the last slide. This is a cost of doing nothing. People die, and their quality of life is really horrible. 1 in 150 people with uncontrolled seizures are going to die from something called SUDEP, that's sudden unexpected death in epilepsy. The amount of lost productivity and quality of life in these patients when they don't get referred and don't get a treatment is quite significant. So there's absolutely no question that the field is going to continue to address and push on this. And it's also quite clear to me that the best treatment we have to do this is responsive neurostimulation for all the reasons that we've talked about here. So I'm obviously very excited to continue this. We have a lot of work to do, but it's really exciting, and it's helping a lot of people. It's going to continue to do that. So thanks for the opportunity to talk.